Just a little point of clarification. Patty Graham and I work together as colleagues. We've done different projects on related topics, and we're going to, Patty's going to follow me and talk about issues related to dissemination of a project once it's completed, and I'll go through this first project with you about team training. And, okay, got it. All right. So the project that we're going to discuss first, it was multidisciplinary team training to enhance family communication in the ICU, and I have to also disclose that the project PI was Dr. David Shaw, the head of graduate medical education at Scripps Mercy Hospital. I joined him as a collaborator on the study and as a co-investigator, along with Dr. Renee Smelda, Tarani Sanduzzi, and Donna Agan. So we were an interprofessional team that conducted this study together. At one time, I worked at Scripps Mercy while this was being conducted. And that's the prettiest picture of Mercy I've ever seen. It's nestled in a 100-year-old neighborhood of San Diego, one of the oldest neighborhoods in San Diego. The sidewalks are imprinted from 1906, and it definitely looks a little rougher around the edges than this beautiful photograph. And Dr. Shaw is in what I call Oslerite. At Mercy, there's a tradition of opening every program with a little reflection, and he always uses Osler quotes in his talks. So if he could have been here today to present his own work, he would have used this one. The work of an institution in which there is no teaching is rarely first class. It is, I think, safe to say that in a hospital with students in the wards, the patients are more carefully looked after, their diseases are more fully studied, and fewer mistakes are made. So in his honor, I put up the quote that he generally uses at the beginning of his talks. There's a picture of him at the top, Tarani Sanduzzi, and then Donna Agan underneath. You didn't need a picture of me because I'm standing here. And Dr. Renee Smelda hid from us. So Renee is a palliative care expert, and those people, as you know, are often very skilled at communicating with families during complex patient-family conferences. Tarani is a psychologist that works with our EAP department, and the EAP department there is very active. Everybody knows her when she walks down the hall. They can say hi to her as a local psychologist that helps out staff through difficult situations. And the two of them coordinated they facilitated the training that we designed. They executed it. And Donna ran all of our numbers for us. We'd like to acknowledge the staff, of course, and the physicians that participated in the training, then the GME department at Mercy for their partial funding for the project. It was internal funding, and then also the nurse manager of that ICU paid for the nurses and other staff to attend the training. So that was a great gift, and I don't think the project could have been done without it. So Mercy is a level 1 trauma center. It's a 36-bed ICU split into like 3 physical locations, but the staff and physicians rotate between those areas. So, and that's kind of important when we get to the design of the study. It's a faith-based medical teaching hospital. So the research questions that we looked at in this project were, will multidisciplinary staff training to conduct a family conference improve the staff confidence in communicating with families? And staff, meaning staff and physicians, so attendings, residents, chaplains, therapists, and nurses. Okay, and will multidisciplinary staff training to conduct family conference improve family satisfaction with communication in the ICU? So we actually looked at the family response to this intervention. We decided on a pre and post design because this was a single center study. We could not do randomization or even randomization of units because the staff go back and forth between the departments, and there was no way to prevent spillover bias by randomizing into groups. So we decided to go down a notch to the pre and post design to preserve the integrity of the data. We used the FSICU with open-ended questions for the family portion of this, and that's a validated tool. We sampled until we got 64 complete returns in the beginning and then 64 complete returns after the end of the intervention, 30 to 60 days after the patient was discharged or died. Oh, let me go back. Maybe. There There we go. And then for the staff confidence survey, again, we used a validated tool by Bale using matched pairs before and after. So we waited 6 weeks before sending them the after tool instead of just measuring their confidence immediately at the end of the program, which you might anticipate would go up. So we waited for 6 weeks. We got some back as late as 8 weeks after the education, and used that staff confidence survey. And the standardized family vignettes were also used prior to our study, and we obtained permission to use those standardized family vignettes. So there was a role for a doctor and a nurse and a chaplain and a therapist. But when people came to the program and did the simulation training, they pulled a role that may not have been their own to practice in, and it really getting people outside of their comfort zone of their natural role was very enlightening to the entire group. And then the only thing we changed about those vignettes was we made the name of the hospital local to us. So we took out the name of the old hospital it was first tested in and put our own name into it. But that's the only way we altered the tools. So for the intervention, I mentioned that the management team paid to any staff that wanted to attend, but it wasn't mandatory. You know, it's not. Traditionally, we don't mandate involvement in research, right? So they could come if they'd like to, and if they did, they got paid. And we sent the FSICU to a baseline group. Then what we did, this is the part that I think was unique and novel, and I really liked the most out of all of it, was we had an open-ended question at the end of the FSICU about anything they wanted to tell us about these aspects of care. And the FSICU has 2 subscales to it: care, and then involvement and decision making. So the second half is all about communication. And what we did was we had the open-ended question. So on the baseline study, when we sent that out and got it all back, we took all the comments that were open-ended, and then we sorted them into constructive comments or praise. And then we put them on 2 sides of a piece of paper, and we handed them out as pre-reading for the people that were coming to the course as part of the learning, to be able to stimulate a more burning platform for change. Because as you know, most ICU staff and physicians are very proud of the work they do. And you don't normally, most hospital patient satisfaction surveys don't really get to the ICU population cleanly. They usually answer their satisfaction surveys based on their experience outside of the ICU, like the last unit they were admitted to. So often the ICU staff doesn't have a clear impression that there's any reason why they should change or improve. So by sending this out, getting the feedback back, taking those comments and sorting them into positive and negative, they could see that this wasn't just an academic exercise or what if we improve this. They could see that there were some real issues we needed to address that was coming from the voice of their own patients, people that they may have cared for directly. And then we assigned them 2 articles to read as pre-reading, and then we started scheduling teams of 8 to 10 people at a time to come in for training, and Tarani and Renee held the training repeatedly over and over and over again, little 2-hour trainings with mixed-up teams, all different professions. So we had the attendings, the residents, chaplains, nurses, and therapists. All right. So the confidence survey, they were given after the registration to class, but before they came to class, and then they were also given that later at the end, as I said, 6 to 8 weeks out. And the course included information about the Buckman or Spikes protocol, key elements of how to conduct a conference, opportunities for improvement based on those direct feedback quotes from our own patients, and their family members, and then they were each given a simulated role. They did the role-playing of a conference, and then there was a period of simulation debriefing at the end of each training program. And as I said before, they were facilitated by our EAP psychologist and the palliative care specialist. So in the end, we 52% of the people we invited came, so 98 providers participated, but we only ended up in the end with 46 matched pairs, and because that's how we set up our data analysis a priori, that we kept to that with the 46 matched pairs. I do need to disclose that when we went back and evaluated the data from the entire group, whether they were matched or not, there was no difference in the findings. But you could see we have a small number of intensivists who all participated, and these are very seasoned gentlemen. They've been there for years and years. We were very pleased that the entire intensivist group came and played with us on this project. Residents, nurses, only a third of the nurses came, 76% of the residents that were invited came, and you can see down the list. And then when we were done with it, all was said and done, every element on the confidence survey improved for everyone in the for overall in the program. So all 21 elements addressed on that survey all showed improvement to statistical significance. So on the family satisfaction end of it, the FSICU, this is really kind of fascinating because, as I told you, there's 2 subscales to it. And if you take just the subscales related to communication, there was a significant improvement in 3 of the 7 subscales related to communication. But that just moving the points in those 3 areas, just making the improvements in those areas, changed the significance, altered the significance of the entire subscale. So the entire subscale was statistically improved by moving those 3 in the right direction, which means to me that we moved forward the things that were important and needed to be addressed, okay, because the entire subscale was statistically significantly improved by the end of it. So other issues were not, but this may mean that we just did not have as much room for improvement, so it's harder to show significance, right, if you don't have as far to go with those areas. And there was no significant improvement in there's 2 subscales, one on communication, the other one on care. There was no significant improvement in the subscale on care, which is probably a good thing because we weren't doing anything to improve care. We were doing an intervention to improve communication. So if the subscale on care had improved, we would have had to wonder to ourselves if the results in the communication section were truly related to our intervention, if you follow my logic, right? So that, I think, was good all the way around. So what are the limitations to this project that we did? Well, there's many. Of course, it was a single-site study. We had only a 52 participation rate, which some of you might say is really good, but we would have liked better. We don't know if the participants actually cared for the exact patients that ended up filling out the surveys. We don't know if they actually received a family conference based on the results of this training, so that was not, we didn't have that demographic data to make it, to make that analysis. Now this is really kind of a silly thing. The matching didn't work, our matching plan. So we asked the staff, college-educated professionals, to write down for themselves the last 4 letters of their mother's maiden name and match themselves up later, and they couldn't do it. So we had nearly half of the sample size could not follow that instruction. And I don't know why doctors and nurses can't remember the last 4 letters of their mother's maiden name, but it didn't work, so don't try that, okay? So that was like, sometimes the simplest things will throw you down in these studies. Okay, and then of course the design was not randomized, so if you really wanted to get a broader generalizability out of this, you'd need to do a much larger study, maybe randomizing by unit. And then the length of the training style was limited, cycle was limited by trainer availability, so we had several months where we were training people, and you'd think that that trickle-in effect might have diluted the results. If we had a good, strong bolus and got everybody done all at once, then the teams could have practiced their new skills together, whereas the way it was done, you might have, after somebody was trained and then a doctor and a nurse were doing a conference together, maybe the nurse had been to training but the doctor had not. It took several months to get everybody kind of up on the same page. So that might have diluted. If I had it to do differently, I would have made the training all in bolus, like very quick cycle for the training. The strengths, now this is this is where this whole thing about interdisciplinary teamwork and interprofessional training, this is where this comes in and why I personally think it's so important, but it's so hard to execute. In the past, the nurses were all taught Randy Curtis's model of family conferencing, and the doctors were being taught the Buckman-Spikes protocol, right? Because we were training our people separately. It's not that one is better than the other, or it's that you should do one versus the other, or we landed on Spikes because the value method wasn't the right one. That's not it at all, but people should be trained to do it the same way if you're working as a team. And because we were training separately, we didn't even know that until the start of our project. So we came upon that little problem and then had to standardize to one thing. And now since then, the nurses and doctors are all being trained on the same method. Okay. Let's see, when they worked together and they had to simulate each other's roles, it was funny sometimes that, I remember observing one of these training sessions, and the resident pulled the card of respiratory therapist, and then he was playing down his role in the family conference, and the facilitator says, well, why didn't you speak up when they asked about the ventilator? And he says, well, the respiratory therapist shouldn't be speaking in the conference, right? And that started this whole dialogue about what people's roles really were on an interprofessional team. So it really brought up all those little nuances between where are the boundaries, where's the scope, and what do all members of the team have to contribute. Then we really thought that the comments, sharing the open-ended verbatim comments, we scrubbed them, of course, for name and to make sure that they were blinded enough so that they couldn't tell which patient turned in those comments, but they were pretty much pure comments. And to take a very proud, experienced team with a really senior staff and get them to feel as though there was a need for change, we thought that one piece of the intervention was very important, and that we would advocate to anyone else in the future that if you're doing a project like this locally and hoping to improve local responses, use local examples to help do it. It really puts it forward. And then by keeping the positive comments too on the other side of the page, it preserved the dignity of this very respectful, experienced team. So they got to see both sides of it. So our opportunities, again, would be to randomize, redesign the process of sample pairing, speed up the training cycles, and maybe monitor and enhance the adoption of training into practice with more academic detailing. We didn't do any of that. We didn't go out after the training and follow up with staff during conferences to make sure they were following the protocol as advised or following the sequencing as advised. We just let it run and saw what happened at the end. But in real life situations, you'd want to, if you were doing this as a performance improvement project, you'd probably want to go out there and do much more academic detailing to make sure people change behavior once they've learned something in a classroom environment. So that's the review of that project. And now I want to do is take just 5 minutes and transition you from the whole issue about patient-centered outcomes research. Once you're done with the project, it should be disseminated into practice. And once it's disseminated into practice, it should somehow come alive in your department where it's no longer even anything somebody has to think about. It's enculturated. You're just doing this new way of work seamlessly and almost effortlessly, right? And what are the challenges to disseminating this into the real world? Well, I'm going to take the example of family-centered care because that's where my expertise lies. That's what I study intently, and I've read most of the literature on this. And this year, at the bottom of that screen, you could see I published in the ATS journal a complete review of family presence on rounds. Like I reviewed every single document ever written on the subject and put out the review. And if you just take the threats to disseminating the act of allowing family presence on rounds, the what-ifs that are posed in the literature are, what if family presence increases time spent in rounds? What if it decreases the quality of teaching? What if families are scared about what they've heard? What if witnessing our work causes physiologic harm or psychologic harm? What if family presence causes a breach in HIPAA? What if they sue us, right? And on the side of visitation, the threats are like, what if family presence presence causes physiologic stress, and what if family presence causes infection? Well, none of these things have been found to be true once they're studied, but if you look at the qualitative work where they survey staff and physicians, these are the problems and concerns that they raise, even though once they're studied, they do not hold true. So how do you get past the staff feelings about these things to get a change in practice to occur? These are the threats to dissemination, and I call them the what-ifs. So if we go back to the example of the case that I just went through, the project we just did at Scripps Mercy in San Diego, let's take that example and see after it was done, what were the threats to dissemination, right? Well, we had 4 sister hospitals within that health system, and one of the 4 hospitals successfully implemented the training. But that was just before a downturn in the economy and a decrease in the budget for education, right, in the organization. So at this point in time, the managers of the other ICUs couldn't easily pay their staff to come to a 2-hour training for family communication, right? So at this point, the threat is, do we have the educational dollars to support disseminating to the other sister hospitals using the same methodology to get the same results, right? So how do you get recruitment without paying people to come, right? How do you get staff to want to go to a 2-hour session on this if you're not going to pay them? Because then it's a whole different ballgame, right? So what we're thinking of doing, this is what we've been brainstorming, and we're just about to the point of putting this together, is we're thinking, what if we want to broaden this out, not even just to the ICU, but out into the wards. What if we take the cases that they're most concerned about dealing with and do the training simulations about how to do a family conference about that issue? And in this organization, the number one concern or the number one challenge for staff and physicians is dealing with a patient that's psychiatrically has a mental illness but is there for a medical problem or a surgical problem. So what if we designed all of the training kind of around that issue, but use that issue in that case to teach team training with interdisciplinary conferences, see? So then the participants might come because they're interested in that topic as well as interested in learning about team training. So we were thinking about focusing on the most challenging or emotionally draining cases that we could possibly think of to stimulate their participants in team training. The other threat to enculturation, now that we're done, new people come in, right? You can't just put in a training program for existing staff and stop. Okay, but the orientation processes are completely different. The nurses are trickled in all throughout the entire year. The new doctors come in July, right? So, and their orientation processes are completely separate from each other. How do we do team training, though, on a routine and regular basis to catch up on people who hadn't gotten the training before? And that remains a challenge that hasn't been overcome. So the message here is kind of what to adopt is different than how to adopt it, right? We can know what we want to do, but how do you get it done? That's where the real rub is. And there's unintentional drift in technique as you push things out to the masses. And when I was reviewing the literature related to rounds, I'm not making this up. This isn't just out of my personal experience. I didn't watch somebody on rounds doing this poorly and then write it on a slide. I mean, people are actually publishing this in the literature that when they've tried to, performance improvement literature, when they've tried to put family presence at rounds, they notice that sometimes the attendings are mean to the residents in front of the families, okay? So how do we prepare ourselves to not let that happen, okay? So even if the entire medical staff agrees to we're going to allow family presence on rounds, how do we make sure the how of it is done in a way that will produce the same outcome as original research? Talking over their heads, or having family presence without family inclusion. So those are 3 threats to replicating an outcome of what was originally designed or intended. So at this point, what I'm going to do is transition to my colleague, Patricia Graham from UCSD, and she has a perfect example of how she took something which seems so simple as family presence on rounds, got the entire medical staff to agree to do it, And then when she went to put it in place, I'll let you hear her end of that story, okay?